with that. Also, this meeting is being recorded, um, as I think you just received the notice. So with that, I would like to turn it over to Dr. Hopkin.
Okay, I hope you are seeing my first slide. I'd like to thank you for inviting me to this presentation, and we will go forward. This is not a scientific review. It is some things that I felt stood out. There are more things that were presented at the meeting, but these are some of the talks and presentations from the World meeting. I'll just give a brief summary and description of why I thought they were worth spending time on. Okay, so this one, so the patient voice was something that got a lot of attention at this meeting. 20 years ago, when I first started into Fabry disease, and I would go to meetings on Fabry disease and how to take care of the patients, there were usually no patients at all in the room. And I said, well, where are the patient representatives? And people looked at me like I had three eyes. And this session, or this meeting, they had a 2-hour session just devoted to the importance of getting the patient perspective and considering that. And they included talks on best practices for including patient representatives in study design, methods of surveying and listening to patients to identify unmet needs, patient groups. There was one talk that was not specifically on Fabry disease, but a patient group had decided what they wanted done, had raised some money, and then started reaching out to scientists saying, we want somebody to do this. So just the recognition that your perspective is a key part of making all of this work, I think is really important. And it was a big change from what's previously been done. So another thing that got a lot of attention, and there are a couple of abstracts that I am highlighting here, were how to communicate within a family. So if you have a patient diagnosed with Fabry disease, then you want to track other family members and see who else might benefit from being tested or learning about Fabry disease. So Dr. Germain and his group did a survey of families and said, what are the barriers within your family that keep you from reaching out to family members? And the first ones, not surprisingly, were denial, depression, being upset with the news that the patient has gotten, whoever the first patient was, and then lots of social stigma. There were also people who noted geographic separation, which interferes with certainly with face-to-face communication, but in some cases also with even how well you know the family members. And then financial constraints. You don't want to do things that are going to put people into a bad position or cost them more than they can afford, but we do want to make sure that people have access to the health care that they need to stay healthy. So as ways to address those issues, they pointed out working with the patient advocacy groups, so groups like FIN, to help with some of this, sample letters, which they were suggesting that providers like me or the patient advocacy groups have templates for how to write a letter that tells people you might be at risk for Fabry disease because this is what's in the family. And then fact sheets, printed materials, and other things, and just make it as easy as we possibly can for families to communicate about Fabry disease. And then the second one was same general thing, except that this was in places where they're doing newborn screening. So Dr. Berlina is from Italy. They do newborn screening for Fabry disease. So they had 26 newborns with a confirmed diagnosis of Fabry disease. All 26 of the mothers, so all of those were males, and all 26 of the mothers were also affected with Fabry disease, and then multiple family members in most cases. Some of the other family members were not affected with any symptoms at the time, but did need evaluations, and some of them did have signs, but not symptoms of Fabry disease. Signs are things that we find on lab studies or that the doctor might notice, but that don't bother the patient. Symptoms are things that the patient notices that interfere with their life in some way. So some of the patients were truly symptomatic, but had no idea that they had Fabry disease. And their point was that in the newborn screen diagnosis, the first person in the family diagnosed is going to have usually no evidence of an illness at the time that they are tested and that the diagnosis is made, but that there might be a lot of other family members. And that complicates the issues that were talked about on the previous slide. So making sure that we're addressing these issues was kind of a high-profile topic at this meeting. Then this one is by patients, which I really liked. So the the group in Canada, the support group in Canada, did a survey of the US and Canada, and they got 92 people to fill out the survey. And the overwhelming response was that women are treated differently than men, that often their symptoms are dismissed and ignored or just not taken seriously. And then some things that don't get as much discussion as that topic, because that one's fairly well known, but it's disturbing that it's still an issue. But they asked, what was the hardest time period for a woman with Fabry disease? And that was felt to be the time of family planning. So women of reproductive age, and especially when they're considering having children, is a major stress and something that more information is needed on. Symptom management, interestingly, was also not very well addressed. And we'll talk a little bit more about that in another slide. Over 80% of the people who filled out this survey reported that Fabry disease affected their mental health, leading to anxiety, depression, and sometimes other forms of distress. And the large majority of the women reported that primary care physicians just do not understand the challenges facing women with Fabry disease, and that most of those physicians were not interested or did not seem interested in learning more about Fabry disease and how do we address that. So this is an issue that has been known, but I think that it's important to highlight that both Canada and the US have good access to healthcare throughout the countries, and this is still a major issue, and we are trying to find better ways to address that. This is another study on females with Fabry disease. And this one was also a survey, but survey with a chart review. And the question that they wanted to know was how much involvement do patients have, and particularly patients with late onset disease. So in their survey, and I don't remember how many patients were included, but 70% of the women had multi-organ involvement. This is from the Follow Me registry. Just to clarify. So the common places of involvement: peripheral nerves, so a neuropathy and acroparesthesias in 71% of the women surveyed. Renal disease, primarily proteinuria, in 43%. Cardiac disease was more than 45%, but left ventricular hypertrophy was the most common reported problem with 45%. Palpitations was in 29%, and they did not tell me how much overlap there was between those two. Central nervous system, which included a couple of things, probably stroke, and I don't remember what the other things that they included were, but 50% of the people were thought to have some central nervous system involvement. 27% of the females had hearing loss, and 52% of the patients had GI symptoms. Now, this is the Follow Me registry is a very different population than the previous registry-based studies, the FOS database and the Fabry registry, because they are predominantly classical, with a lot of nonsense mutations and frameshift mutations that make little to no enzyme. The Follow Me registry, almost by definition, is going to be predominantly mutations that are missense and where there can be some enzyme present. And so it's going to be at least somewhat enriched for cases that are probably not as severe as the null mutations that make no enzyme. So that means they have different biases, but these numbers are pretty much comparable to what has been found in the other registries. which leads me to conclude that these numbers reflect sort of what's going on in the patients that we are currently finding. Now, we still don't know the later onset mutations aren't being well captured in any of the places right now, primarily because we're not even making the diagnosis. So it's hard to collect information on people that you don't know about. This is another one that I thought was interesting. They didn't have a lot of information in this, but aging in Fabry disease. Now, when I started working in Fabry disease back in the late 90s, we couldn't find any patients with males with classical Fabry disease who were more than 60 years old. Finland now has at least 23 patients, and they are getting closer to a normal lifespan. Have a long way to go to get to where we want to be, which is a normal lifespan with a normal quality of life, but we're working on it. Several people had died. About half of those died of causes related to their Fabry disease, predominantly heart, but heart and kidney. I think there might have been a stroke as well. But some of them died of things that are not at least directly related to Fabry disease. There were a couple of cancers and other things that would, not that that Fabry disease couldn't play some role, but that wasn't directly Fabry disease. And I think this is, on one hand, a group of people that we need to learn a lot more about, because we're going to have questions coming up more and more often as we get more people aging. And it's something to celebrate because we need to start thinking about this. And that means we've made progress over the last 25 years. Okay, now some more technical stuff. So anti-enzyme antibody measurements were a very hot topic. I think I have 3 slides on this. So in this, up to 40% of people on ERT will have antibodies. In this one, they looked at subtypes of antibodies and also tried to look at other inflammatory biomarkers. They found that all of the subtypes of IgG, which are the most common kinds of antibodies in your body, were elevated, that the IgA subtypes were also elevated. IgM and IgE were also found, but not as frequently, much less frequently, and they didn't have enough data to fully characterize those. They also noted that in some cases you saw only IgA, and you still had some signs of inflammation. And in some cases, you didn't have any antibodies, but did have complement activation that targeted or appeared to be directed at the alpha-galactosidase. So that has a couple of implications. One of them is that the immunity related to the enzyme infusions is more complicated than had been realized. Now, there's a lot of information that's not on this slide. When they broke it down more, they found that 17% of females and 25% of males had antibodies. In this study, IgG4 was the most frequently associated, most frequently elevated type of antibodies, and it was also the type of antibodies most likely to inhibit the enzyme. So they thought that that was potentially an important thing. Unfortunately, in this study, they did not give us any clinical data, nor did they give us data on the biomarkers like lyso-Gb3 that we use to see how well we're treating. So the antibodies, yes, that's important, clearly important. It's related to infusion reactions. It might, in some cases, it's related to decreasing the amount of enzyme that gets delivered into the cells that we want to use it. But they did not have enough information in this presentation to let me know how much of an issue that is. Okay. More on anti-alpha galactosidase. So another one, this is another study. And in this one, they were looking specifically at the newest form of enzyme that's on the market, the pegylated enzyme that was developed by Protalix and is now available through Chiesi. And they found that that new antibodies developed to both anti-PEG antibodies and anti-alpha gal antibodies, both occurred. Anti-PEG antibodies were present in 33% of the patients that they looked at, and anti-alpha galactosidase A antibodies were in 47%. The half-life of this enzyme was longer than alpha galactosidase alpha and beta, both with and without antibodies. In this study, the anti-PEG antibodies did not appear to change the drug half-life, and they didn't have any data on what, if anything, it did to the efficacy. And there were no serious infusion reactions that they identified in this study that were related to the anti-PEG antibodies. The anti-alpha galactosidase A antibodies did have some neutralizing effect, but did not appear to have a significant clinical effect. As far as they could tell in this study, they also noted that many of the patients decreased their titers with time. Now, this is a related but slightly different topic. Oh, I already covered most of this anyway. This one is a different study, but the males and females with antibodies, numbers of neutralizing antibodies were lower in this study than for either agalsidase alpha or agalsidase beta. So the antibody story, there were other things on it, and the role of inflammation as a driver of the complications of Fabry disease was another topic that was touched on, but I didn't have enough details on that to make many comments. There's more to come on this. I think it's important to recognize that while the antibodies are very common, most people with antibodies related to the infusions still appear to get most of the benefit that they could from the infusions. So not everybody needs to be worried about this, but people who are having recurrent infusion reactions, or people whose disease appears to be progressing, and especially if the symptoms are progressing and the lyso-Gb3 levels are going up. Okay, the next one, biomarker evaluation when patients initiate migalastat. So that's the oral chaperone. And some of the patients started without any previous treatment. Some of the patients switched from agalsidase alpha. Some switched from agalsidase beta. That was the smallest group, I think. What they found was that the GB3 and lyso-Gb3 analogs assessed in this study, which was a pretty good panel of the variability of those analogs, the ones who had previously been on treatment, essentially all of them remained stable when they switched. They did not go up, they didn't go down, they just stayed the same, but that was starting from a place of being treated. The people who started without previous treatment saw decreases in GB3 and lyso-Gb3. And as far as I could tell in the study, it looked like successful treatment in the patients that this study recruited it looked the same for each of the available options for Fabry disease. Now, migalastat biomarkers too. So this was a very hot topic, got a lot of discussion. This was another study looking at alpha-galactosidase A activity in patients on and off of migalastat. So white blood cell activity went up significantly, which means that migalastat gets into the white blood cells. And based on its volume of distribution, it should get into almost every type of cell in the body. In the hemizygotes, which is the male patients, the level of alpha-gal activity was quite low, 0.4 to 5.0, and rose to a median of 20.5. In the female heterozygotes, there was a lot more variability. I rose a median of 20.5, not to 20.5, but went up by 20 points in the men. In the women, there was a lot more variability of what the baseline was, but the amount of increase in what was in the blood, in the white cells of the blood, it went up 73 points, which would put that the normal range for this is, I think, from the 70s up into over 100. So the patients who were switching, again, the lyso-Gb3 remained essentially stable. So what you can take away from this is that migalastat, inappropriately chosen patients, gets into the cells, makes active enzyme, stabilizes active enzyme, and allows it to work, and that appears to be comparable with some of the measures, at least, to what we get with the enzyme infusions. But that was complicated by this presentation. This one was 44 patients, and this was when they switched from agalsidase beta to migalastat. They were a mix of late onset and classical. Decline went up. Decline in renal function went up in all of these patients, or on average for these patients. And but the left ventricular heart wall thickness decreased in the subset of patients that had late onset variants. So it appeared to be some mixed data on areas of benefit and areas of concern. And of these 3 studies, none of them had enough details to really know what the drivers of the changes were. So this is an area that we need more information on, and I am happy to discuss questions, but I think at this point, it's an area that needs some more carefully designed studies, and that there is some disagreement in the outcomes. We don't know if that's a patient selection process or what the drivers are for the differences in the results. Another area that was, I think, very interesting was functional biomarkers. So hypercapnia, which means breathing fast, leads to vasodilation in the brain. Hypocapnia, breathing slow and not as deeply, leads to vasoconstriction in the brain. And in patients with Fabry disease, when they asked volunteers who were in the study to overbreathe or underbreathe, their blood vessels overreacted. And that is, on the surface, not necessarily something that's really important, except that it points to a couple of things. One is that the abnormal blood vessel reactivity is likely to be a risk factor for stroke. And the other one is that function, dilation or constriction is in part neurologically mediated, and that shows that the neurologic system in the patients is overreactive. And that supports a central nervous system phenotype for Fabry disease. So because of both of those things, I am interested. But we need more information. This is another one. This is just a way of trying to get better data on what it's like to have Fabry disease. So a group in England asked for volunteers to pioneer an app in which you could enter your symptoms. And they had a good number of people who signed up. Most of the users entered data only once, but they said, yeah, this isn't too bad. I could use this if I need it. But there were some people who really liked it, or at least appeared to, because some of the patients who used it entered data up to 600 times. And but being able to track data and see how it's changing over time and have people be able to enter the data without having to come into a doctor's office, I think has some value and can teach us a lot about the disease. Cognitive and mental health challenges is another one. Jack Johnson was one of the investigators on this one. And they did some questionnaire-based evaluations. Fatigue was, so they had a number of things that they gathered some data on, but this abstract was specifically on cognition. Fatigue was the second most common complaint that was identified across the board for Fabry patients and was the most common one related to cognition. Brain fog was the 11th overall and the second most common related to cognition. And they both support that there is a cognitive phenotype. Then looking at behavioral and mental health, depression was highlighted and was clearly prominent. The abstract did not mention anxiety, so I don't know if they had data on that or not, but I would guess that that would also need to be seen. And in other studies that have been done on this topic, both depression and anxiety were well above what we would expect in the general population and even above some of the other comparable chronic diseases. Treatment burden, how hard is it to get treated? In this study, they looked at, you can see the percentages, people getting 3 of the current treatments. And it was noted that, getting the treatments is difficult. Acroparesthesias were recognized as being important and recorded on the patients in the medical record as being a significant burden. And in this study, so the numbers up top are just who was on what treatment. The numbers in the middle are what percentage of the total patients in the study had those things. Now, there was probably some ascertainment bias in this, so there might be overrepresented. The thing that I thought was most important on this was in this study, the physicians caring for the patients recognized that these things were a big burden, contributing to poor quality of life and poor health. But the number of people getting treated, 37% had no treatment at all given to them. And yet the physicians caring for them and the patients recognized that many people had symptoms and that these symptoms are important. And in fact, more patients were being treated for the symptoms there were not 37% with nothing being done, but 37% without a Fabry specific. So they're trying to treat the pain, but not treating the cause of the pain. That doesn't seem like a good thing. This is one looking at monitoring in people on and off treatment. So men had 70, in this study, the men and women who were on treatment, 72 and 73% had cardiac involvement, 66 and 63% had neurologic involvement, and those are not significant differences. Mental health was reported more frequently in women, so 28% of men, 38% of women, and treatment for that was offered in 20% of men and 31% of women who had those problems. So you can see that we have high levels of involvement, and that there's not as big of differences between men and women as have sometimes been assumed, that only the mental health and proteinuria were statistically different. In the untreated population, people who did not receive a Fabry-specific intervention, 46% of the women and 35% of the men had had an echo, and they did not report any information on renal monitoring in the untreated population. But what this tells me is that the people who are being monitored and may be doing okay at this point are not getting the testing that we should be giving them to make sure that we are going to recognize changes or progression of the disease faster. You're well under 50% receiving what would be standard monitoring. So mechanisms of hypertrophy, this one was fairly simple. Having hypertension and Fabry disease predicts more risk for progressive left ventricular hypertrophy. And then there was another study that looked at inflammatory biomarkers, and they did a fairly sophisticated way of looking at those and looked at gene expression related to inflammation and gene expression related to structural proteins in the heart, and found that the structural proteins did not correlate with the degree of LVH, but that the inflammatory biomarkers did. And they hypothesized that the key driver of the left ventricular hypertrophy in Fabry disease is inflammation, and posed the question of, would targeted anti-inflammatory interventions be helpful in controlling the Fabry disease? ERT and cardiac dysfunction. This one looked at the standard measures like heart wall thickness and arrhythmias, but they also looked at diastolic function and specifically at something called diastolic reserve, and found that that was a much more sensitive and predictive thing to measure as far as how is this patient going to do over time, and that it changed with treatment where the standard measures usually do not. And they stated flat out that the best thing to measure is diastolic reserve. I don't know that all cardiologists would agree with that, but that's what this reported. Identifying symptoms in kids. Don Laney was the lead on this, but not the presenting author. One of the things that they found, so this was looking specifically at GI symptoms, and what they found was that a lot of the GI symptoms that are identifiable in young children were not ever recorded in the medical records. Bloating and severe pain being the earliest findings. Constipation and diarrhea were sometimes, but were often missed. And the conclusion was we need to actively look for signs and symptoms of Fabry disease, not passively wait for people to report problems if we want to catch them early and get best opportunities for treatment. Let's see. Another thing that was interesting, this is only one, but there were at least 4 presentations on modified enzyme that is made specifically designed to promote optimal uptake and to be stable in the pH of plasma, so as it's going through the circulatory system. so that we can deliver it more effectively. And this particular one was also looking to have less frequent administrations of medicine, and thought that they could do subcutaneous injections using a pump like people use for insulin now. But they are still in mouse studies, so it's not right around the corner. And we will stop there. And I think we have some time for questions, but probably not a lot of time.
Thank you, Dr. Hopkin. I will step in for Jack. He had to step out for a bit. I think we have one question in the chat to start with, and a very long question. I'm just gonna see if I can make it shorter. So with the question with the information on biomarkers, we can measure different treatments and measurable differences between Fabry subtypes. Does this help us understand when it's the best time to treat different subtypes? Because this wildly varies in different countries. Also, does this also help us in any way with NBS and predictability of disease subtype and clinical pathway? This is from Bob Stevens. So if I said something differently than you wanted to ask,
that is
then please chime in. But let's give
No,
Dr. Hopkin a chance to
I
respond.
think you're pretty well on the number with that. It's with NBS newborn screening.
Yeah.
Yes.
So that is a really good question. And I think it does give us information on when to treat. Particularly, I did not highlight this, but there was a study that looked at how soon do some of the biomarkers go up. And they go up very early in life, and then they stabilize. There's been an assumption that babies and kids have lower levels of storage material in their blood. They probably do have lower levels in their body, but not in their blood. It sort of gets to a level and then stabilizes. So we shouldn't use that. To treatment. Now this is old data now, but Tondell et al. Looked at kidney biopsies as the biomarker and showed that if you treat kids, you get much better clearance than if you treat adults. So we need to do a lot more work, but it is pointing to earlier is better, and possibly much earlier is better. But we need a little more data before we can come to a final conclusion. It also looks like in a child who's identified by newborn screen, we can probably classify them or their family members based on a preliminary level of the biomarkers that we have. So we can say, is this in this family, is it likely to be classical? Is it likely to be later onset? And where on the later onset, there's a whole bunch of variability, but we could look at, who are going to be on the mildest end and who intermediate, and then the classical patients. We do not know how much it's going to help with monitoring treatment. I think if we do our homework right, we'll find that some of the biomarkers are good for monitoring treatment, but that's right now pretty controversial.
Okay, thank you. We have another question here that reads, was there anything presented regarding data on gene therapy, longevity, especially as specifically data on the longest from dosed patients?
So yes, there was. There were actually at least two that I can think of. One of those studies is currently closed, but they're trying to get back on track. And that was the company 4DMT, and they have a gene therapy that's targeted to the heart. The patients that were treated with that have had sustained expression. It appears to be good for the heart. They are on hold right now because of some inflammatory complications, specifically hemolytic uremic syndrome, which can damage the kidneys. So they have to have a plan for preventing that, and then they will try to get up and running again. Another one that was presented is the Sangamo gene therapy trial. That one used a different vector, and they had high levels of enzyme production and no major complications or even need for interventions to prevent the inflammatory. They had some fevers, but no significant health issues related to the infusion of the gene therapy. And they have high levels of expression. The longest patients that have been out that were presented at this meeting were about 3 years in, and they had no decrease in expression. And the patients in the Sangamo study reported an improved, the patient reported outcomes. So pain, GI symptoms, and general health-related quality of life were improved. And they had positive effects on the biomarkers. So from all of the standpoints that we could measure, it looked promising. Another thing, though, that was very prominent in this meeting is that a lot of the people who are working on gene therapy are running into problems raising the investment dollars to be able to do the clinical trials. Both 4DMT and Sangamo are having difficulty with that, but so are essentially all of the other companies. There are several other companies that were there but not reporting data, and a couple of them said they already have the money to go all the way through the phase 3 clinical trial, but nobody was, that was a huge issue. And that is an important issue from the community of patients with lysosomal diseases, because we really need to get better treatments with less burden of care, and we think that gene therapy is likely the highest.
Okay, we have some additional questions coming in. Was there any discussion regarding alternative pathomechanisms, ER stress, oxidative stress, and so on?
There was some. The oxidative stress is related to the inflammatory cascade, and that was a common topic both in Fabry disease and in the other lysosomal storage diseases. There are people working on targeting those pathways for secondary treatments. So if you stop the storage, but you don't stop the inflammation, the disease will still get worse. If you stop the inflammation, but not the storage, the disease will still get worse. So they're thinking if you target both, you can probably get better outcomes. related to Fabry disease, that was discussed at least twice, but was not the major topic. But some of the other lysosomal diseases, that was the major topic in actually 2 sessions. It were focused to inflammatory biomarkers and their implications for lysosomal storage diseases.
Okay. I have a question. I have a personal question regarding females with Fabry. What do you consider to be the best way to educate the general practitioners on the fact that females can be as much affected as male patients with Fabry disease?
There is a paper that is either in review or soon to be in review, in which we changed the model. So up until now, women with Fabry disease were lumped in with men and or compared to men with Fabry disease. That inherently minimizes the impact on the women. So what we did, and Angela Walter, Sean, also at Sanofi, Don Laney and I are the sort of key people involved with this. What we did was pull all of the data on women and compare the burden of Fabry disease, the risk for heart problems, kidney problems, GI problems, pain, stroke, etc., with the general population. And then some of those symptoms where they overlap, we compared to other chronic diseases that everybody knows should be treated, like diabetes. And what we found is that women are far below, have much higher risk and a quality of life far below that of the general population, and comparable to that for diabetes, MS, and rheumatoid arthritis. And we hope that that will convince people, hey, you need to take this seriously. That's, as far as I know right now, the best thing that we can do. The thing that patients can do is talk to their doctors about what they have, but make sure that you do that in a realistic way, and preferably not a confrontational way. You are a bad doctor, but no. We want you to go in and say, hey, I'm having this problem, and I know that this problem is associated with Fabry disease. Can you help me do something about it? And I think doing that will help at least your local providers to understand, but that takes a long time. And we're trying to overcome, I mean, it's been 20 plus years now, but since we figured out that we really do need to include women completely in this disease, but for the 30 years before that, it was pushed pretty strongly that this is a male disease. And if you look at anything before 2006, that was published before 2006, it's going to say that. And some of the papers all the way up until as recently as 2016 or so were still saying women are pretty mild. And it's just not true. So hopefully this paper will help.
Thank you. Yeah, couldn't agree more. We have another question. Was there any information regarding the possible pathogenicity of common missense mutations, like A1
There was
143T and likes that?
So yes, there was a lot, but it didn't clarify very much. There was a lot of discussion about it. There was a poster on A143T that was only a single family, but it had a father and 3 daughters. One of the daughters was worked up for proteinuria. She had a kidney biopsy, and she had typical findings associated with Fabry disease. Clearly had storage. She had the genetic test, was found to have the A143T variant. Her 2 sisters, one of them had no symptoms. And when we did some baseline labs, all of them were in the normal range. And the other sister had GI symptoms and some fatigue, but no signs of heart disease or kidney disease. And most of her labs were in the normal range. I think she had one thing that we looked at that was outside, but not enough outside that we could be confident that that was related to Fabry disease. We are trying to get the dad to come in so we can look at him and see what his numbers are. The current understanding of A143T is that that mutation produces the amount of enzyme that is right on the line between pathogenic and benign, but in the milder end of Fabry disease. And other factors besides that variant are going to slightly increase or slightly decrease the amount of enzyme that an individual makes. And some people will have effects of Fabry disease and some will not. So it is a truly variant of unknown significance on an individual basis until you get worked up. The question is, what do we need to do to work that up? And the other question is, can we find out what's causing, what are the variables that are leaning people one way or the other? The other ones were mentioned as being of unknown significance and being controversial, but there was no substantial update on any of them.
Okay. I think we're slowly running out of time. I'd like to, I think was a very, very promising and very positive to see so many papers and posters from patient advocates and patient groups where patient groups were involved. So I think that's increasing.
Yeah, that was really remarkable. And we actually had a session. This one wasn't on Fabry disease, but it applies to Fabry disease, in which the discussion was all about the emotional and psychosocial impact of first having an unknown disease, something's wrong and I don't know what it is, then getting a diagnosis that seems like bad news, then the challenges of getting access to treatment, and then finally just looking at life from a different perspective. And they had that perspective discussed from the perspective of the patient, the parents of that patient, the siblings of that patient, and the care providers, the doctors and pharmacists and other people involved. And it led to a pretty open discussion of just the emotional burden that we all, it's not exactly the same for all of us, but it affects everybody who is involved even distantly with these diseases. And we need to talk about that, recognize that it's an important issue, and try to address it.
I think that's definitely something we can relate to. Thank you to the audience for participating and for the great questions. And obviously, thank you, Dr. Hopkin, for your excellent presentation and for explaining so many difficult things so well. And happy Valentine's Day to everybody. And have a
Happy
great day,
Valentine's
great
Day.
evening, great good night, wherever you are. So thank you very much. Bye-bye.
It was very useful, and you were always, very good on, deliberate understanding of all these difficult, presentations. Thank you all for your participation as well. Anna, thank you very much. Jack as well. And see you next time.
All right. Bye.
Bye.
Thanks, Dr. Rob.
Sorry, Jerry, I didn't have time to see your last comment or question.
Well, it's not really that important here. It's just something we need to work on.
Okay, I hope you're well.
Well, I am. Thank you
It
very
was
much.
lovely to see. It was lovely to see Casey in San Diego, and we're happy to get her to come to the Fin Expert meeting as well.
Yes,
Yes.
we are very excited. Yes.
Yes, it'll
That'll
be
good
fun.
One of these days I'll get back on the road, but I don't.
Yeah, but you should
No,
concentrate on yourself now.
Yeah. Well, it's just I'm doing well health wise, but I'm still afraid to fly. I just
Okay.
I wouldn't say afraid is the right word. I don't, because I take transplant medications, I don't really have a good immune system. And even though I've had 8 vaccinations for COVID, I'm still not protected. So,
Oh my goodness, 8.
yeah. So just to give some context, when I do titer tests for my protection, my wife gets 10 times the amount of antibodies that I do. So I have a very low level of protection from getting COVID. But I'll get
Okay.
back on the road. Meanwhile, nice to see everyone on Zoom.
Yes,
Yes. Nice
yes,
to
and
see
it'll
you
be
too,
fun
Jen.
to have Casey come
Very.
join us in Prague.
All right, hey Mary.
I'm very excited too.
Yes, yeah.
Oh, you're
Hi,
there!
there you
Oh,
are.
I didn't see you were there.
Oh, I was off video for a while. Then I
I'm
heard my
so glad I
name,
didn't
so I
say
had to.
anything negative about you.
Thank God.
Mhm.
Casey said she enjoyed meeting you all very much.
Yeah, as if I would. Anyway, I think we need to let Charlotte go. So I think we need to leave the meeting. But
Let's
it was
make-
good to see everyone.
True.
Bye-bye.
Bye-bye. Thank you very much. Bye.
Thank you, everyone.